motion to approve the minutes for December.
Motion to approve.
Second. Favor. So we have no correspondence. So Don,
So
you're up.
what's up?
You're up for the committee report right now.
Oh, all right. I'll get back to that. Okay. So academic committee meeting. Everybody was here for it. I'm not sure what I have to basically say, but Dr. Cordy and Dr. Hassett are our new members of the academic committee. They will be bringing treats next time, they said.
That's your important job.
Supposedly. The academic committee is going to be changed the name to the Remac Operation Advisory Committee. The thought was that was more likely what it does rather than really being an academic committee. The academic committee, when I joined about 30 years ago, did the protocols, and that no longer is what is occurring. So this seems to be a more reasonable name for what we currently do. Let's see, EMS charts being able to use for students. Mike is going to bring it up to the next council meeting, see if we can get a educational EMS chart program available for new EMTs. There are a number of courses, I won't go through those. It was suggested that we have a bottom line but basis for provider impression, which everybody has been, I think, here, so the discussion. And that's basically it for academic.
Okay. So have Dr. Anderson here to talk about suicidality EMS. Background is he is a psychologist and an active writing member at Delmar Bethlehem. I have to look at Steve.
So I'll start by, we good? Okay. I will start by apologizing. A few of you in the room have already heard me say this a few times. I'm sure it's getting old for you guys. But I'm here to sort of just start with a little bit of context about suicide and EMS, some of the risks, and then a little bit of some of the stuff we started to talk about doing about some of the things to do about that. But to put things into a larger context, some of you guys may know this, but suicide in the U.S. it's one of the leading causes of death throughout the lifespan. If you look pretty much from adolescence through middle age, it makes the top 5 for Americans. The only reason it's not higher later in life is other stuff starts to kill us. But middle-aged and older males in particular have incredibly high risk of suicide in America. It's just that other stuff is getting us as well in those age groups. It's also one of the relatively few causes of death still on the increase in America. We have had nationally, this is some CDC data from 1999 to 2016, we got a 28% increase in suicide rates in America. And in New York, we're right on par with that. We've been 29%. So a pretty significant increase in risk over the last 20 years or so. So specifically for EMS, so to put that into the larger container, this is a problem we're having culturally and socially in America in general. Specifically for EMS, this is the big national survey that came out a couple years ago that suggested that rates of suicidal ideation and suicide attempts are much higher, roughly 10 times higher in EMS than they are in the general population. So we've got an increasing general risk, and within EMS, specifically first responders more generally, we've got elevated risks above that. There's some newer data that's come out that's pretty much in line with this. Some other data from some other sources suggesting you are a pretty significant risk depending on how you look at it. So the big question has been why. This is something we spent a lot of time studying, a lot of time working on. And I'm going to give you sort of the leading theory about suicidality. This is Thomas Joiner's theory of interpersonal theory of suicide. It's probably driving a lot of our research these days, and driving a lot of our treatment these days. And basically the theory says you have to have 2 things for suicide. You have to have the capacity or capability to commit suicide. That is, and most of us seem to be, I don't know if it's hardwired, but sort of born with a reluctance to commit suicide. It has to be trained out of you. So there's this capability, And then there's also the desire. So there's lots of people that have the capability, they could do it, they just don't want to. They never have any desire to. There's also lots of people who have the desire, but they can't bring themselves to do it. So you need both of those things. And so kind of in this little zone here in the middle, there's two parts to the desire for suicide. And we don't have to go into a lot of the details, but basically it's feeling like you don't belong and feeling like that you're a burden to others. Things would be better without you. You know, the world would be a better place if you were gone. So that's that desire for death, the desire for suicide. So there's lots of people, again, who have one but not both. You put them together, and that's where we see high rates of suicidality, suicide attempts. And here's what's specific for EMS. Experiencing EMS, experiencing any avocation, occupation, lifestyle, where you see a lot of death, you see a lot of pain, you see a lot of suffering, that starts to wear away that natural inborn capacity, that natural inborn barrier to the capacity for death. So the problem is, this is why we see high rates of suicide across first responders more generally. That's why we see it in firefighters as well, we see it in cops, we see it in ER physicians, we see it in other people that spend a lot of time around death, spend a lot of time around suffering. It doesn't have to be a job. You can just have a rough lifestyle. I've seen a lot of death growing up, where you work, where you live. So this is the problem for EMS, is this is built into what we do. It's never going to go away. So anybody involved in EMS, anybody involved in first responders more generally, at some point in their career, sooner or later, it's going to end up with this sort of natural capability or the natural reluctance to commit suicide. That capacity starts to be built. And this is sort of and this is that reduction in the fear of pain, reduction in the fear of injury, reduction in the fear of death. It's also, in EMS in particular, that we're pretty good at knowing what will do it. Same thing with military. You put capacity for suicide combined with a familiarity with firearms, and that's why we see high rates of suicidality in the military. We see it in EMS because we know what hurts and kills people. Right? So, and again, I just point out, you need all three. So when we're thinking about prevention, well, we need to think about where we want to intervene and where we want to think about making those changes. And we can't change that capacity for suicide. One of the things we have, at least so far, there's some research being done on it right now, but as far as we know, once that capacity is there, you can't train it back out. It seems to be, once it's gone, once that barrier is gone, it's gone. Once that capacity is there, it's always going to be there. I know a couple people are working on this right now with some research. Who knows down the road if we come up with this, but that's not where we're looking these days. So capacity, we sort of say, once that's gone, once you're in EMS for a while, you're going to have this. We're going to assume that's going to happen. What we want to do is change the desire. Right? Work on that, not, I can do it if I need to. We want to work on that, but I don't want to side of things. And that's where really all of our prevention work is being done, really more on this prevention side of desire versus capacity. So we've spent a lot of time, and I go to a lot of conferences now, and there's a lot, I think there's this assumption that it's the people who respond to that bad call that have a really, really bad call, and that's what does it. That's sort of what puts them over the edge. And I'm not saying that never happens, but what it seems to be is that's not really the common factor. This is not like a PTSD-related issue necessarily. And I think that's how we've kind of framed it for a while. It's really more that seeing all those bad calls, being on those things, that builds that capacity. What we're really seeing driving a lot of this is normal, everyday life stress stuff. Can't pay the bills, getting divorced, those kinds of things. Car broke down, lost my job, whatever it may be, that makes people really stressed out. But without that kind of capacity, they're depressed, they're stressed, they're overwhelmed, but they're unlikely to make a suicide attempt. You put somebody who's got that capacity in with those sort of major life stressors, and that's where we'll see that kind of combination. If we do see these bad calls, and this is my best guess, I haven't seen a lot of data on this, it's that bad call is tied with you've got the capacity, and then the person feels like it was their fault. I did this because of my actions or inactions, somebody died, and EMS and the world would be better without me. And so that's relatively minor, again, in terms of numbers compared to when you actually ask people who've made suicide attempts who've survived what their stressor was. It really seems to be more of these kind of common, ordinary, if you will, everyday stressors that many of us have that pushed them over because they had that capacity. So interventions. We have been talking a lot about this at the various meetings. I'm going to focus on one of them in particular because it's kind of the first step I think we're going to take in the area and maybe the state. And it's looking at a type of gatekeeper training. There's probably half a dozen of them out there. The one that I'm familiar with is QPR. I'll talk about it. It's a training program designed for the provider level. It's designed for, in this case, your EMTs, paramedics. I was involved with the program. We had a suicide prevention program at the University of Albany, where I'm a professor. I was involved with that, and we taught essentially a version of QPR there, and we taught it to all of the RAs, anybody who dealt with students that might be upset. So RAs, financial aid office, any professors who were interested in it. So it's designed for kind of the street level. This is not a psychologist, a medical intervention, anything like that. And it's based on the assumption, and what we know is that most individuals will make some communication about their suicidality before they make a suicide attempt. Sometimes this is overt. I'm going to kill myself. It might be, if you leave me, I'm going to kill myself. Those kinds of overt comments. But more often, it's these sort of coded comments. Hey, you might need to fill my shifts next week. Or, I know you've always liked my guitar, you can have it. Something like that, where the person's making an attempt where if you kind of read between the lines, there might be some suicidal ideation there. So we think that the overwhelming majority of individuals will make some comment like that, because even with that capacity, people are still relatively ambivalent about the desire. Right? There's always a subset of individuals that are not going to tell anybody, or not going to do anything. There's no way we can say, we can really tell in advance. But that's a relative minority of the people who make suicide attempts. Right? So the idea behind gatekeeper training is to train people to detect these, to kind of listen and hear in between the lines, hey, this sounds like that could be something that's problematic, right? And respond to them. Okay? The reason that this is really important, and we want to train everybody in this, or as many people as we can, is people may only tell one person. You're sort of reluctant, you make some comment to your writing partner or whoever, or your friend, and they don't respond the right way, they may go, well, nobody cares anyway, right? And then they're done, right? They don't tell anybody else. So the idea is to as many people as possible to be up to speed on this sort of training, so that everybody gets a chance to maybe notice this, so that we can make an intervention. So this is really sort of the equivalent of first aid, in the sense that you're detecting, you're starting to do something, but you're really getting them to a higher level of care. That's all this is. This is not an intervention in the sense of doing any sort of therapy. It's really intervention in detecting and helping a person reach a higher level of care, whether it be a physician, a psychologist, or whatever, some sort of in any of those realms. So this is what QPR stands for. It trains people to question. And so this is the hardest one to train, the hardest part. Basically, it's getting people to say, hey, what did you mean by that? Or hey, you seem really overwhelmed. Have you been thinking of hurting yourself, killing yourself? And it's interesting, EMS, we're pretty well trained to ask embarrassing questions and probing questions. Whether or not we're really good at asking that of our friends and colleagues is a separate issue. So what we do is we train people to do that first. If they say something like, yeah, actually I have been, and people, as far as we've seen in using QPR and other things like it, people are actually relatively open about talking about the stuff. If they made that comment to you, that's sort of the lifeline they're throwing out there, and if you pick it up, they're okay, they are surprisingly okay of talking about it. So you persuade them, hey, are you willing to get some help? Are you willing to go with me, ideally, like sort of right now? And that's what we would do at the university. We had people would go, you're coming with me, I'm walking with you over to the health center, and we're going to go together to have an emergency appointment. If not, when you make an agreement to not do anything until we can get you in, there's a lot of things you can do to persuade. And then the important piece here is referrals. So having a ready, if someone says yes, you can't go, let me get back to you on that in a couple of days, I gotta go look up some people. So one of the things we're really trying to do is come up with a database of, whether that be EAPs, whether that be providers in the community that are willing to see patients who ideally have some experience with first responders. I'd rather have somebody who's really good at dealing with suicidality and not great with first responders than somebody who doesn't know anything about suicidality. There are a relative few mental health professionals in the area that do have experience with first responders, but there's a lot of people that are pretty good, let's say, at dealing with the suicidal crisis. So that's really it. Are you suicidal? Will you get help? Here's some help, right? And getting them in. And then you hand them off to the higher level of care where we can start doing this. The the overwhelming majority of individuals who commit suicide, somewhere, you know, we know this from either retrospective or survival studies, survivability studies, about 90–95% have some sort of diagnosable mental health disorder, axis 1 disorder. A lot of substance use, a lot of depression mainly. I mean, those are kind of our top two. We have treatments for depression. We have treatments for substance use, right? So if we get these people into treatment, we can often get them through that suicidal crisis, which is really not usually weeks and months. It's usually relatively short-lived. We get them through the suicidal crisis, we get them in treatment, we improve their depression, their PTSD, whatever it is, and often those people don't ever have a second one if we get good treatment. So that's QPR. That's what we are starting to roll out. I'm just waiting for my final paperwork from the QPR people as an official trainer of this. The thing itself. Go back to that second. QPR takes about an hour, hour and a half. You can do the training. You can do it as more of a lecture in an hour. You do a little bit of an experiential piece. Takes about an hour and a half. So it's about a 90-minute or so preferred. That's sort of the preferred time. You can do it up to 4 hours if you really want to get into lots and lots and lots of scenarios. But yeah, think about a 90-minute investment of time. That's what we're talking about. Groups of about no more than 25, maybe 30, just because you want it not so big that it feels like a lecture. Nobody's willing to sort of come forward and talk about this stuff. So that's what it is. The nice part about it is that by working at the provider level, or at the sort of the EMT level or the medic level, you're changing that culture about being able to talk about the stuff. That's one of the things I think is one of the biggest benefits. You know, we're not great about talking about being in distress. And if people get some practice and get some training at being able to talk about being in distress and ask others about being in distress, it might change that culture we have of silence about distress. We've seen some interventions in the military trying to do this kind of in parallel. You know, not incredibly successful, but it's a slow ship to turn around. And I think EMS is the same thing. If we start working on that, as people come into it, as people get more familiar with it, if we start early, we can kind of slowly change that culture so people are more open and willing to say that they're in distress and to get help for that distress. That's it. Questions? Those are my two email addresses. That's my SUNY email and my Del Mar Bethlehem email. I check both, probably check the SUNY email more often. But we're going to start rolling these things out in the area. I'm going to be doing these trainings, at least one in each of the surrounding 6 counties. Is that what we decided? Surrounding 6 counties over the next few months, just to sort of pilot it with the various EMS agencies that are willing to do it. And then from there, kind of come back and maybe look at doing this more broadly. So, questions?
Drew, besides you, is there anyone else out there, say, between now and when this actually rolls out and the program becomes more beefed up? Who else other than you in 6 counties can handle this?
Anybody who wants to take a week's worth of, I mean, they do essentially a home training. So you can, I am the only one I know of right now. I'm sure some school districts have been doing this in their region, at least I know. I don't know of anybody personally, so as far as I know, I'm it. But it doesn't take a lot of work. This is not a mental health specific intervention, meaning anybody can take the training that's interested. It doesn't have to be a psychologist, a social worker, anything. Like I said, a lot of school counselors will do this, and they'll do trainings for the teachers. But I'm the only one I know. But it'll take you about a week or 2 to get up and running if anybody wanted to.
Dr. Oshkow, the REMSCO discussed this at our last meeting, and we're glad we have Drew. The REMSCO would be very willing to sponsor any agency that has a provider that wanted to take the training. If they would, we would pay for that training if they would be willing to serve as not only a presenter for their own agency, but throughout, you know, do some CMEs throughout the region. As Drew said, this is, you know, we got to train everyone, so to speak. So we're going to do 1 CME per county. You know, maybe that'll attract 100 people or 150 people. You know, we've got many hundreds more than we would like to get to.
I mean, as these things go, it's just under $500 to get trained, and it's good for 3 years. The only thing they ask is that each person that takes the training gets a little pamphlet with a wallet card of like how to ask questions, and it's $3. And then I haven't looked yet, but I think if you buy a bunch of them, they're less than that. But sort of to read, they charge $3 for that, which is not bad. And it's, like I said, it's a wallet card and a little pamphlet, so it explains everything.
The region voted to buy a couple hundred of them. Yeah. We came up with a number, eventually we should decide we should double it, but I forget which number we doubled.
$2,000 for the initial,
Okay.
but if it rolls out, it's popular, I'm certain the REMSCO would be willing to spend whatever's needed.
If anybody is interested, I mean, in the larger sense, I teach our class, our grad class in assessment. I've taught suicide assessment for a long time. If anybody is kind of interested, but they're a little bit not so comfortable with this and aren't sure about the training, I would be happy to work with them just on a little more comfort with talking about suicidality, because it's something that I spend a lot of time doing and training. I train our grad students in our suicide assessment stuff, so a more thorough suicide assessment.
Drew, would you be willing to do it up at Vital Signs? Because you would have a huge audience up there.
Sure, yeah, I'd be happy to. I mean, the only issue is really, really large numbers, and maybe at that point, if we've got a couple of people to help out, I'd be happy to do it, you know.
Even as a pre-conference,
Yeah.
that would be probably you'd still need help, but it would be a more manageable number.
And you know, if we want to run a series of them, you know, that's fine, you know, do a few of them or something like that, so they can keep the numbers okay. I'm happy with all that. I do want to do all that.
Any other questions? Just tagging onto this, there is a task force started by the region. Steve Kroll is chairing that. They've had a couple of meetings of that so far, which have some fairly interesting topics coming about resources that are available that a lot of people don't even know that they have access to. And Steve's also on the committee to take care of this at the SEMSCO. So if you have any interest in that, get in touch with Steve. Thank you. Does anyone need to take a break now? Yeah. And honestly, it's not much of a meeting, so give me 10 more minutes, or you take a break now.
Do it.
Keep going. So, REMSCO, any other highlights? We approved Dr. Daly continue being our CMAC rep. We had the suicide discussion, and I don't think a lot of other major issues that came up. SEMSCO.
So for CMAC and SEMSCO, approval of New York City protocols, which are out of the collaborative protocol, and probably the only area now that doesn't follow the collaborative protocols, unfortunately. But there was a fair amount of discussion, but it's just not going to happen in the near future. As far as updating protocols, there was a large discussion on exactly how that's going to happen, but once we actually have the actual dates of how it's going to occur, protocols will only be updated once a year, so it won't be every 2 months we'll end up having another protocol update, unless there's something emergent that comes out. So once a year there'll end up being a protocol update, and at that time there'll be education, and it will be not quite as chaotic as it was over the last protocol update. CMAC is now going to be meeting 4 times a year. The dates for the next meetings for CMAC and SEMSCO, March 10th and 11th, June 9th and 10th, October 6th and 7th, January 12th and 13th, and that's at the Hilton, downtown Albany. Parking isn't quite as convenient, and I suspect you have to pay for it, but
$11.
that was, what was the $11? Is that
I
what-
think that's what.
And Mike brought up, though, for STAC, it's still out of Troy. For whatever reason. Vital Signs are going to be at Saratoga this year, so it's a lot easier for a lot of us to get to. Everyone wants to go there. October 29th and even November 1st. EMS Memorial Day, I believe is May 19th. If anybody does want to attend that. That's basically it.
Do I
Deb updated us on CARES. There's a 2019 report coming out soon. Big discussion, though, was primarily the provider impressions, trying to get those kind of finalized, and they were advanced to the Operations Advisory Committee, is what it's known as now, for further discussion and possible presentation of the Remac. Paul and his group have been doing a lot of work in trying to get a standardized list together, and they have a great list that's been passed around so far. I think at the moment we're just going to see if there are any other additions right now that people want or need, and then hopefully have the final list soon. So that was pretty much the largest chunk of our discussion. From there,
And that actually was put forward as a motion for this group to vote on whether or not to accept this.
Just this list? So we're not waiting
With-
for any additions?
With the additions that we discussed in the
Okay, so that's where this will take part now. Let's see, we had some updates from regional meetings, but that's essentially the quality, the QA meeting. So do we have to bring this up now? Okay, so the motion was advanced, motion was put forward to advance these to this committee for acceptance. Did I say that correct? I think so. Okay, yeah.
That's good. I'll second it. That was a motion.
Yes.
All in favor? January meeting was canceled. Updates, Stanford Heights is added CPAP, no ALS upgrades, BLS first responder, East Jewish Fire Department and Pleasantville Fire District, both updated, no EPCRs, PAD, G and Schenectady, Wildwood, Express Scripts, and U.S. Department of Housing and Urban Development have updated. Express Scripts and G were original. New business, ET3 update. Anyone bringing
So,
that?
well, quick update from at NEMSP. As this group knows, we have 4 applications that were put in regionally to participate in the CMMI initiative of ET3. At this point, the feds are saying that they promise that they mean March when they say that the approvals will be granted in March, and that they didn't mean that the approvals would be granted at the end of 2019 the way they thought they said. They actually mean March. We'll just have to wait and see exactly what that means, and then move forward from there. We're also working on one district initiative with both the Alliance and Benny about alternative destination and other options for EMS patients, and we'll see how that goes. So hopefully we'll be able to reduce patients transported to the emergency departments when they frankly can be treated in place or can be sent somewhere else. Cross your fingers and hope. What?
Any word in the second round?
No word on the second round. They got to finish the first round first.
They said they were gonna come up with another.
Yeah. Yeah, with any luck, they'll actually figure out this whole thing, and the buy-in from the insurance carriers will continue to grow. Certainly, the insurance carriers that we've discussed this with locally have been extremely supportive of the concept, but CMMI is the big one.
Next is just topic of coronavirus, and if you have anything particularly you wanted to say about other events out there.
A couple of things, actually, the Department of Health, the County Department of Health wanted me to assure everybody here that they're working really hard on plans of what to do if they have people of interest that they find, both in terms of well folks that have traveled and are being quarantined, and also about potential ill. I'm sure each hospital is also concerned about this. Something that arose as part of some of those discussions along the way is that for a long time, the state of New York has required every hospital to ask every single emergency department patient as they enter what their travel history is. gotta be honest, I didn't think about it before, but that's really kind of daft, because they miss a significant proportion of their patients who you all bring to the hospital on their travel history before they've already touched us. So what I would like a small group of us who oversee public safety answering points to consider is the idea of the emerging infectious disease surveillance cards and how those cards can impact our callers and how our call takers can deploy those. So whether or not we should be using those for our sick patients and for our respiratory distress patients. Because if we've already contaminated an ambulance and potentially exposed a crew, they're gonna get in, and at the med, I can just see somebody now, they'll get in there, they'll sit at, third ambulance in line, waiting to check in, coughing, before we get a mask on them, get them in a room and ask them their travel history and find out actually they were in an area that was endemic for MERS or something else. So, if a couple of the docs that are active with public safety answering points can stick around afterwards, we'll talk about that. I think that would be best.
And the final thing on the agenda is we're due for our every 6-month letter to the state saying we're going to continue using expired drugs. So can I get a motion for that?
Using the expired drugs that are on the state's list.
They're on
of
the state's list that we
approved-
can't use, but we need to have permission to say that we're doing that. Yes. It's only the 5th time around, so.
So moved.
Second, any discussion? All in favor? Okay. Any other topics for discussion? Yes.
Several months back, this body approved a change in the turnaround documents, reducing the number of CMEs required to 20 if a provider was enrolled in the CME program, but leaving it at 24 if they were not. Unfortunately, we didn't address the AEMT groups without having Dave Bettini here to remind us that those agencies existed. We kind of overlooked that. So I'd like to request someone on this body to make a motion that we reduce the number of CMEs required for AEMT agencies to 17, which is 1/3 of their requirement of 50, and would keep them in line with the paramedic CCT groups, agencies, excuse me.
So moved.
Second? Motion. Second, Chairman. Okay, all in favor?
All right.
Any other topics? No?
I had one.
Yes.
thing. Do you have any word on telemedicine and EMS?
That's
Sir?
the whole ET3.
But ET3 includes telemedicine that's rolled out right now?
Yes.
That's in effect in Rensselaer County?
I think I think she's referring to.
Concierge.
Rensselaer
Yeah.
County has a
Concierge.
specific contract with United
Yeah.
Concierge. But
Does
that's not-
Reno have a policy on that?
No.
Are you gonna have a policy on that?
Right now, it's not really from a region.
What's your
From a
concern?
region, it's not a thing yet.
What's your concern?
Well, Rensselaer County wants to roll it out for Tri-Fire and for all EMS, not just Mohawk.
Sorry, Dr. Fitzpatrick.
Rensselaer County wants to roll it out for all of EMS,
Mhm.
Tri-Fire. And so, we're not comfortable doing that until Remo has a policy on it.
There was
There's,
time in ET3.
Well, the basis of all of our ET3 discussions was the idea that we would be doing telemedicine with remote credentialed physicians for dispositioning of patients, which I don't think is any different. I mean, it's obviously adding different potential courses of treatment than we do now for refusals, for example, but I don't have a problem making a motion saying that remote credentialed, and let's think through how the motion should say, but remote credentialed physicians can provide telemedicine to direct the care of patients in the field with EMS.
Well, let's be careful exactly what we're saying here, because are we saying that Troy Fire all of a sudden is gonna call St. Peter's, we're going up on the screen, we're gonna be doing telemedicine with them?
If you set up a program, but if you don't have a program, I'm not saying you should FaceTime it, but if you set up a telemedicine program and there is point-to-point conversation between the two.
Because right now it's being done by Landmark, I understand, right? Isn't that who's doing all
Well,
that?
Landmark has been doing this on 10-digit calls for 2 years.
Totally
2 years?
different program.
Yeah.
Totally different. That's not an emergency call.
Right. Plus it's with
Rensselaer County is,
different
yeah.
providers with different destinations. I think although there are some things that are similar, there's a lot of things that are very different. And I don't think that we're ready to let that go yet until we actually have ET3 sort of done, proven itself.
How can we do ET3 without what we're talking about right now?
Well,
which
right now,
is the
ET3
key to
is
doing
a
ET3.
pilot, if you will. And I look forward to it being completed and it showing the data that we expect it to show. But right now, we're gonna put the cart before the horse. If we say, sure, go ahead, set up a program. Because right now, then, if you do that, you can say, sure, stay at home. And remote physicians are gonna get phone calls saying, should I bring this person to the hospital, should I not?
But it would have to be a remote physician with a telemedicine program that meets the CMS requirements for a telemedicine program, which takes all the, I'm just a remote doc, somebody's gonna call me, off the loop. Because telemedicine, you actually have to have a visual contact with the patient, which you're not gonna have over the phone. So only one of these agencies that has that set up is even gonna be able to do this.
And it like guaranteed follow-up.
It's running right now.
Steve, why don't you explain, the question was from Chris Floyd with Troy Fire, and,
Yes.
and the model we're doing in Rensselaer County.
Mhm.
Maybe you can explain to the group.
Sure, I'd be
a
glad
little
to.
bit. I'm not trying to run into your meeting, but it seems to be a little confusion, so.
Sure. For those who don't know me, I'm Steve Kroll. I'm the Vice President of EMS and Hospital Integration at United Concierge Medicine. We are a telemedicine physician practice based in Troy, New York, and we have formed a partnership with CDPHP that is now gone live in Rensselaer County, and is now CDPHP is expanding to 16 counties. That will bring our virtual emergency room for low acuity patients and make it available via telemedicine to patients at various levels. One level is starting with the Medicaid population. Patients contact us directly, and we provide assessment, navigation, and treatment for these low acuity patients rather than going to the emergency room or using some other higher level of care. Number two, we work with the 911 PSAPs in the counties to have low acuity calls potentially diverted to us by a warm transfer for the 911 operator after they complete their EMD and determine it's a call that's eligible. And so that's now begun in Rensselaer County. We're going to begin working with PSAPs throughout New York State. We're working with other major insurers as well. Health Now is pretty close to starting this. MVP is pretty close to starting this. And the third way is an EMS crew on a scene can identify a low acuity patient if we have a partnership with that EMS agency, like we have with Mohawk Ambulance right now. And that patient can be triaged to us by the EMS crew to get to do the telemedicine visit. The idea here is to lower Medicaid expenditures by providing the right care, navigation for patients that probably do not belong in the emergency room, but today use the emergency room for their care.
Who are your docs?
We are a medical practice. The CEO is Keith Algazine, who is a PA, worked at St. Mary's and worked in Troy. Our medical director is Mike Bibbinghouse, Almost all of our physicians are remote credentialed physicians. We have many of them. We have close to 100 providers. Some of them work part-time, some of them work full-time. They're located either in our region or throughout the country. We have close to 1 million enrolled lives in our commercial marketplace, so we work in 15 or 20 states. So for example, we operate a virtual ER for a 6-hospital system in Kansas City. We operate a virtual ER for a 6-hospital system in Dallas, Texas. We are very present in the commercial marketplace. For example, we are an employee benefit for every employee of Steward Shops. All the employees of Stewards can use us. This is relatively new. Last year, we began contracting with insurance companies to bring this to the Medicaid population, and that's what we're up to.
When you say to a 911 call that you have a virtual ER program, would you like to talk to the ER doctor? Somebody has called the 911 system, but as soon as you identify yourself as an ER, you've kicked it up a notch to now the standard of care would be an ER. So we have some concern about the name itself. When you identify a doctor with a phone as an ER, it's disingenuous. I'm a doctor with a phone, and clearly I'm not an ER. And your service is intended for minor care patients, colds and stuff like that. But when you, like even on your app, if you call yourself ER Anywhere, do you want ER calls? Do you want the chest pain call? Do you want the stroke call? Because it's muddying the waters, and it's disingenuous to say to a 911 caller, I'm going to
I
hit
don't
you.
think that's the intention. So when you look at the callers to PSAPs, they're going through all of those EMD cards and coming up with, it's not the stroke, it's not the chest pain, it's the person calling for their kid's runny nose because they don't have a ride or they don't have a ride.
Right,
That's the one you're going to.
You've identified, you've called yourself virtual ER. So that's like, would you, if you wanted to say, would you like to talk to an emergency room doctor, that's fine.
I don't know if they're what the phrasing is going to be.
Well, like when you call yourself an ER, EMTALA applies and things like that.
But EMTALA doesn't apply to this.
Our service is operated with the approval of the state. The name is not a surprise. We went to the Bureau of EMS to make sure this was okay. We went to the state Medicaid director to make sure this is okay. I know Dr. Crisafulli has brought some concerns to us, and I know that we're meeting this week to continue discussing those concerns. If the Remac wishes to have us come before the Remac and make a presentation and have a formal discussion about this, that's certainly fine. There are projects all over the country happening today to try and divert the lowest acuity patients away from the emergency rooms that are overcrowded and to keep our ambulances in service. I understand that Troy Fire has expressed that they don't want to participate in this, and that's okay. There are others in this room that are participating in this or are willing and interested in participating in this. It takes a county government that wants to do it, it takes an insurance company that wants to do it, and it takes an EMS provider that wants to do it. And our medical practice brings those parties together to make this work. If the Remac feels this needs to be discussed here, we're certainly interested in discussing it with you.
I think Remac needs to have a policy about this. It needs to be further discussed. Because we're also, UCM is identifying themselves as a virtual ER, and then EMS is part of their team. Well, I don't want to misidentify. We're 911. We're not part of an ER team. We're in the field purely as 911. We don't diagnose and we don't misidentify what we do. And I think there's, the name is misleading to the population. You can't assume the general population or the Medicaid population to be able to discern virtual ER, which is actually meant for low acuity patients. It's for alpha patients.
And that's what it's being diverted to.
Right, but you've misidentified, what you are by saying we're a virtual ER. I mean, it's just semantics, but semantics aren't important.
Is it the name the issue? Do they have, is it the?
Part of it is also the advertising. They say, call UCM's number or 911. And I think that's dangerous because UCM is an app for colds and 911 is a number for emergencies. And that's another thing. There's a lot of muddying the water. Calling UCM is not the same as calling 911. And that's like step one of their protocol. Do you see the difference between 911 and an app for colds?
Yes. Sure.
I'm confused. If they call 911, are you doing a virtual wallet biopsy to find out what their insurance is and what their coverage is to see if they qualify?
It's the second question.
Yeah.
Do you have
And is that
CTHC?
appropriate for dispatch to be
That's
doing?
not
The second question is.
That's up to the PSAPs.
So let me answer Dr. Chris Foley's question, then I'll answer yours first. At this point in time, CDPHP is doing this, and yes, the dispatchers will ask, are you a CDPHP patient?
Are you
If
a
are not,
CDPHP Medicaid?
well, and CDPHP will be expanding this to all of their business lines. But keep in mind, 9% of the Rensselaer County population, 10% of the Albany County population, and I believe 10% of the Schenectady County population are CDPHP Medicaid. These are tens of thousands of people. So yes, we are going to be asking, but at the same time, we're working with MVP, we're working with Empire, working with Fidelis. You have to start somewhere. And yes, the PSAP has to be willing to ask that question. And in Rensselaer County, they have made the determination that they will. Other counties may not be willing to make that question. So you asked a valid point. Dr. Daly and I are working together on a district proposal that will bring this program, hopefully, in the next few months to all Medicaid recipients in some ways on a broader basis, and we're hoping that goes through as well. Back to Dr. Crisafilli's question, we are very clear. First of all, we're not coughs and colds. We are non-emergency care for non-emergent conditions. That's not just coughs and colds. There is a difference between us and a teledoc service that does coughs and colds. We do assessment, we do navigation, and we do treatment. So sometimes we get people, sometimes people call us and really all they need over the video or phone is reassurance, right? I think I have a big problem. They, after conversing with the physician, realize they need some medical care, but they don't need it at midnight. We're gonna help them make an appointment with their primary care physician for the next morning. We may navigate somebody to e-prescribing, maybe prescribe some medication that will be now prescribed at their local pharmacy. We may navigate them to an urgent care center rather than an ER. We may navigate them to a specialty center like a bone and joint, because that's what they need. We may navigate them for some blood work, and we follow that patient through their episode of care, working with our care coordinators and physicians. But we make very clear in anything we advertise, the first thing you hear when you call us is if you have a medical emergency, this is not the place for you to be, you need to call 911. So we are not substituting ourselves for the 911 service for people who believe they have a life-threatening emergency and need an ambulance. And by the way, this is all voluntary. If any patient is not interested when they're asked, then they're going to be and stay in the 911 system.
Hey, Steve, have any of these patients thus far been navigated back into the 911 system? And if so, do you know that percentage?
We have a 97% non-hospitalization diversion rate so far in our complete Medicaid business. That means 3% of those patients did need to be in a hospital, and we navigate them there. The work with 911 is literally brand new, so I have no statistics for you. I mean, we're less than a month into this. We will have statistics. One of the things that Dr. Daly and I have been working on here with this program is through this grant we hope to receive from the district program is to have a quality professional here at the REMSCO that will be able to help develop the metrics that will sit on top of this program. We as a medical practice have our quality metrics, but we believe that it makes sense for there to be an independent quality assurance that's developed. We make sense, I think, that it be housed here. Obviously, Dr. Daly, as the regional medical director, has been very involved in helping us to develop this.
Right now, when you use the criteria to use UCM, are you using the EMD system? Is that your criteria for determining if it's an alcohol?
We are working with the medical directors of the PSAPs to identify which calls are appropriate. Yes, we've identified through EMD which calls we think are appropriate, but in any locality, the medical director is gonna weigh in as to what that medical director who is supervising that PSAP feels is appropriate. It's all alpha calls, many of them are card 26, which is the sick person, but if you look at many of the other cards, there's that lowest alpha that is cut finger, right? Toothache, and those, some of those are eligible, and of course, that list will change based on what a medical director wishes to authorize.
Is the EMD system really a system for determining lights and sirens, no lights and sirens, how quickly you need to get to the patient? Is that the foundation of that?
ProQA, which is the owner, so to speak, of the EMD, has been working for years now to develop these options for treat at home, including nurse triage like they do in Washington, D.C. There's a diversion program in Fort Worth, Texas. Frankly, we're on the cutting edge here of doing them. It so happens that this is a Troy-based company with local-based physicians that have gotten together to do it. So we really have the advantage of being ahead of the curve. We're developing quality metrics to do it correctly. We've got guidance coming at the regional level to do it. You know, we learn every time we move forward about how to do it better. But that's because this is a new program. And we are fortunate to have partners in this region and in this state that want to do it with us.
It's my understanding, though, that the EMD is a program to determine lights and sirens or no lights and sirens, how quickly can you get to the patient. But the criteria, like, is there a criteria where, like, if you get a patient, the patient has to be English speaking, they have to be a certain age, like, are you gonna take 6 months old, 80-year-olds, like, inclusion criteria, exclusion criteria?
We have inclusion and exclusion criteria. We have language, so we can handle the same language challenges that any other can. We have, you know, I don't have them with me. We have a chief medical officer who's developed inclusion and exclusion criteria. Certainly elderly people with lots of comorbidities are very different for certain things, as well as small children, and we have developed all of those.
I just wanted to point out one more thing. There are some programs that have tried this in the name of decreasing ED visits and EMS use, one of them being a Washington, D.C. program. And they recognize that this is a new program, new territory. They spent 2 years carefully preparing this program where they set up urgent cares to send people to. In essence, they had medical care, medical providers for alpha patients identified. And what the program actually found was it didn't decrease ED and EMS use, and it actually increased the alpha calls. And it grew the program, it grew the calls and it grew the program. So this program, just to be complete, is being put in place with the effort to decrease ED and EMS use. And there is a study that showed that it actually increased use. And I have concern about alpha patients having contact with the doctor, because as you can imagine, the dental patient that calls 911, and there's some confusion about who should call 911, instead of the message being only call 911 for emergent conditions, where the message is out there, if you don't need an ambulance, call 911 in order to get in touch with UCM. And I have concerns about that message. I think that people should only call 911 for emergent conditions. You need to get the message out there about UCM a different way, not through calling 911.
With all respect, Dr. Crisafulli, the ultimate goal of this is to educate people to call us directly. 911 is a way to enter them into the system. After they complete a visit through us, we will be working to educate people, working with local government. In Rensselaer County, all the caseworkers at the Department of Social Services, at the Department of Medicaid, in their aging departments are all working with to educate populations. I obviously was not expecting to have this discussion today and did not come prepared, even though I hope I'm answering some of your questions. We'd be glad to come and appear for you, but I also, I take issue, Dr. Crisafulli, with your characterization of what's happening in Washington, D.C., and you make it maybe seem like we just dreamed this up and like started doing it.
So
There's a
one
lot of
thing
work
to
that's
note
gone.
with the other programs that have been out there, that's been EMS, paramedics saying, you're low acuity, I'm gonna take you to an urgent care. The difference with this setup is that you have a paramedic saying, you're low acuity, let me have a doc see you to see if I can take you to an urgent care. So that's adding an extra layer that wasn't in any of those systems before, which also has them the option of treat and release, treat and take to an urgent care, or no, you really do need to go to the ER. Because remember, these are docs that we work with our department who are doing this. They're Remo docs, they're ER docs. They're not the typical telemedicine primary care doctor that's just doing this because they don't want to have an office anymore. These are actual ER docs. So it may increase some urgent care usage, but they'll also, if you need an x-ray, they'll send you for your x-ray and then follow up on the results. So it's a different setup than anything that's been done and published before.
However, for now, it's ER doc. But as he said, MVP and other groups are. That's why I think there should be a policy saying it needs to be ER docs who do this. So we don't know what these other groups are going to do in the future.
Actually, Mike, I think something is important that we had put into the process as we started ET3, because this really came directly off the ET3 applications, which is that if you are going to be giving or doing medical consultation with EMS providers, you will be a Remo doc. Period. And that was one of the things we said, and I think that is probably a core thing to policy that would, at least establish some of the things that Dr. Chris Foley's talking about, right? The other thing that's important is that DSRIP discussions actually began as a request to get funding to do quality assurance over the telemedicine interactions with patients in the field. Because what we wanted to make sure, and what we were concerned about, was this is already accepted practice in New York State per the Department of Health. We wanted to make sure that if one insurance carrier was doing this with their patients, and another one came along, and then another one, that we would be able to look across that, to be able to look at that cross-section, that there wasn't a spike anywhere in one disease process, one card at dispatch, or one telemedicine provider, for that matter, and make sure that there was somebody that was outside of industry and completely without a horse in the race, if you will, making sure that there was indeed this independent quality oversight. That went directly into well, can we expand this into other populations? And that's where it continued to run from. And something that's been really interesting to see is looking at the list of alpha calls and which ones are appropriate to send to send to the telemedicine provider initially, which ones are not appropriate for the telemedicine provider initially. And those have been discussions between the medical clerks. And I don't know, Dr. Porter, would you like to speak to some of those card 26 in particular, choices in particular, as specific examples? You don't have to start with the one you showed me just now, but you can.
It would make me blush. Anyway, we have also gone through some of the other protocols too, and trying to look where would EMS be actually dispatched as opposed to going to the online physician at UCM and him or her deciding whether the patient really needs an ambulance. And such things are even runny nose or fever and chills, and where EMS dispatch might be unnecessary at the time as an alpha call. Other things might be unnecessary, such as a non-recent injury from a fall to a patient who's been breathing normally under Protocol 18 for a headache, for instance. So there are some things that may be, when we look at all the data after we look at it, that we might change our minds again, but probably an STD might not require an ambulance transport, for instance, and take time out of the 22 corridor in Rensselaer County to bring that patient to a hospital.
So from Rensselaer County, when a 911 call hits their PSAP, is there an ambulance dispatched anyway to provide the telemedicine, or is it just a telemedicine between
I don't know how theirs is set up, but all you need is their phone.
Okay.
We're
So-
still sending an ambulance anyway.
I mean,
At
that's
least
my
in the
question,
beginning.
because despite the fact that you can obviously do a lot of your assessment over the phone, you're still not going to get a set of vital signs or anything like that. So I wasn't sure if there was an ambulance also sent. Because if there's an ambulance sent, then, I mean, you have somebody else there to help with the prioritization of that patient.
The intent is for the lowest security calls for a direct transfer not to require an ambulance to be dispatched. So if you take that alpha calls that are identified, the lowest set will be a direct form transfer to us. But we have the ability to call right back into the PSAP and say, hey, our physician has decided that this patient does require EMS evaluation and respond to an ambulance. So some of them will be direct to us, others will be a dual response of EMS and providers. And the other aspect of this we haven't talked about here is the EMS provider on scene can also identify a patient because, you know, sometimes people call and it's not what they seem. If we are on the scene and the EMS provider has done their assessment using the protocols and feels that this patient has a condition that does not need to go to the hospital, they now can link up with the telemedicine provider to make a decision of whether a treat at home is appropriate or not. And ultimately, the remote physician would make that decision.
Is there a time frame from the time the 911 call gets turned over to your physicians in which they have to respond?
Yes.
Okay.
We have metrics to track, and we answer our calls in 12 seconds. The average time to talk to a physician is 4 minutes.
Okay.
But quite frankly, if it's an EMS-involved transaction, they go to the top of our queue. Why? Because this only works for EMS providers if we respect their time, because their time is money, right? We're saying we can save you time. One of the other things that's part of this is the insurance plans are willing to pay the EMS provider for treat at home. So, you know, right now, we do a RMA, there's no pay, right? So the insurance companies are willing to spend more money to support the EMS providers to supplement the money they would have received if they take this patient to the hospital under the Medicaid program. That's really a new thing because when we now try and involve EMS in more calls, that's a new route to sustainability for EMS, where many of us are challenged today to try and be able to make ends meet. This is a new way for EMS to get involved in the EMS in care.
So Steve, this is not just local. Did you join a big group? Because you're talking about you're in multiple states. I mean, this is all news. I haven't heard of this before today.
Well, we're a national
And I think most
company.
of us
UCM's a national company. We have providers throughout the country. We happen to be based in Troy. We have about 100 providers. We have more than 1 million covered lives through our commercial marketplace and through our work with, we run a virtual ER for the Hospital Corporation of America at 6 hospitals in Dallas. We run a virtual ER for 6 hospitals in Kansas City for HCA. We spent 5 years accumulating the data to be able to go out and talk to insurance companies. And about a year ago, we signed a contract with CDPHP to begin work, and they picked Rensselaer County as their pilot. They announced on February 1st that they're expanding it to 16 counties in New York State. We're close to agreement with MVP, which has a footprint in 20-something counties. Health Now in Western New York, which is in Erie County, which Erie County's population itself is 900,000, which is bigger than our entire capital region, is poised to implement this. So this is I know you haven't heard of it, but this is a multi-year project that's now starting to grow.
So is it just you guys, is it the group here, or did you join a national group?
We are a national group. We have 100 providers.
Right, but did you start here, or did you?
We started here. Almost all of our providers are licensed in New York, but we have many providers that are licensed in 20 or 30 states.
So outside of all of that, I think from a Remac perspective, okay, the most important thing is whether or not, I don't know that we need a motion to support something that the Department of Health has already answered that they are supportive of. But if so, I think what's important for this group to know, just some of the things that we have talked about from an inclusion and exclusion criteria for these patient contacts, okay? And I'll just review those briefly from the DSRIP proposal. General inclusion criteria, and these can be either directly from 911 through Card 26. They can also be from a field provider recognizing the potential for a telehealth encounter rather than transporting that patient. Asymptomatic, these are general inclusion, right? Asymptomatic hypertension, skin conditions with no respiratory distress or fever, joint pain, no fever, injury to the arm below the elbow, like sprains, injury to the leg below the knee, like sprains, superficial first-degree burns, minor wounds or lacerations, including the potential need for sutures. Remember, we're talking about alternative destination. Suture or staple removal, needle stick injury, URI symptoms, no dyspnea and no cardiac history. Dysuria, no fever, age less than 65. Epistaxis, not on anticoagulants. Toothache or dental pain, ear pain, STD exposure, medication referrals. Exclusion criteria. Number one, the paramedic or EMT considers the patient in need of transport to the ED. Number two, patient declines to participate in telehealth service. Number three, the patient or the caregivers are unable to participate in telehealth services. And number four, patient specifically requesting transport to the emergency department. Then there's also relative exclusion criteria, which is patients without decision-making capability. Could there be a possibility for a telehealth encounter here? Depends on why, but that would be something that would probably be engaged at the bedside. Unable to ambulate without assistance, again, relative exclusion criteria. Age less than 3, pregnancy-related complaints, history of malignancy or immunosuppression, surgery within the last 3 months, again, relative exclusion criteria. Abnormal vital signs, abdominal or pelvic pain, GI bleeds, chest pain, shortness of breath, altered mental status, new neurologic symptoms, head or spinal trauma, and loss of consciousness or seizures within 24 hours. So we've built out relative exclusion criteria, general inclusion criteria, some absolutes, all that hover around EMS or the patient decision, right, for participation. And the goal of a regional intervention here is quality above whatever is going on out there through, in this case, a county-funded Medicaid program through CDPHP in Rensselaer County.
Mike, are you involved with this company at all?
No. I have zero conflict of interest, except the interest in making sure that we are reducing emergency department traffic and saving money across the system, while at the same time maintaining EMS as keeping EMS whole. At this point, EMS remains fee-for-service. What this is constructed to do is to allow that fee-for-service to continue, even if the patient has an alternative destination or that patient has a treat-at-home situation, so that EMS isn't taking a hit as part of this opportunity.
So how will that happen?
The insurance companies are gonna pay for treatment.
Because CDPHP has agreed to pay.
Yeah.
And they'll pay for transport to the alternative destinations.
Right.
So if EMS arrives on the scene.
Yep.
And they get telemedicine.
Yep.
Then who is paying the telemedicine and who's paying the?
Insurance.
CDPHP.
So they're
Because the
paying both.
telemedicine
Mhm.
plus the ambulance ride plus the urgent care is still cheaper than going to the ER.
Right.
So it has to be part of that, sure. Steve, one question on clarification. Is it that to be a Remo MD or a board-certified emergency physician and a Remo MD?
Well, the Remo MD, and obviously as we work in other regions, each region will set their criteria as to whether they want to have us be, we all work in New York State under the same protocol, obviously now. We have the collaborative protocol. We're working with other regions to see, do they need to have their specific regional credentialing, or is credentialing in Remo satisfactory for credentialing, say, in Monroe Livingston? Is there reciprocity? That's something that will be made as a decision region by region.
Okay, so it's very helpful.
Yeah, the answer is that if they're going to do it here, they're going to be Remo credentialed.
Well, Remo MD, but that's not saying you're saying a board-certified emergency physician.
Not all of our
Remo MD.
not all of our Remo physicians, even practicing in our emergency departments right now, are board certified. I would love to raise the bar there, but we can't.
I asked the question.
I just want to point out that Troy, where our concern is that the message is going to be changed, where the message is call 911 for non-emergent calls. That's one. Number two, through the system, our alpha calls, which we would really like to decrease, are going to increase, and therefore where there is a chance that we'd be less likely to get to the real emergency in a timely manner because we could be tied up at the scene interacting with UCM longer because we're the eyes and ears of the doctor in the field. And then you just can imagine part of why we're in this predicament, why Medicaid is so expensive and overused, is there's no cost for calling 911 for ED use. And you can imagine the scenario. We're doing this with the effort to decrease EMS use, but we're adding a physician. So scenario, I have a toothache. I'm in the alpha category. Now I call 911 and yes or no, you get an EMS team at your house. But the point is you've called 911, you get a doctor who calls in penicillin, and you never have to leave your house. You've involved 911, which is the most expensive, well, second most expensive form of care, and you get positive reward. You don't have to even go to the ER and wait 4 hours. Now when they come in, they call 911 because they've learned the system. If you come in by 911, you get a bed right away. Nope, we've learned, get off the stretcher, you don't need that bed right away. You have to go to the waiting room and wait 4 hours. There is some negative pressure on these people. It's not fun to wait in the waiting room for 4 hours. Now you call 911 and you get care immediately. You never have to leave your house because the doctor arrives at your house. I just don't think 911 is the forum necessarily where you get a hold of UCM to get a doctor. You can imagine a single mother with several kids sleeping in the middle of the night. You know, my kid's got a cold. If I call 911, the doctor comes to my house and gives me treatment. They can prescribe. There's a chance this could actually increase the alpha calls.
I think in this population, those people are calling 911 anyway.
Agreed. But isn't the message to decrease that?
But give it time. So right now, we're dispatching 911.
On their phone, they're supposed to use they're instructed to access the UCM.
And
They're given an app on their phone that they're accessing, and they did a report on the news a couple nights ago. I saw that Rensselaer County, they said 80, they've used it 80 times, and none of us, we haven't been called.
And our calls spiked when those articles came out because people were downloading the apps and they're calling us.
But the message is to call that app for.
But that's a messaging done by the county. That's not this organization. As far as increasing your alpha calls, the agencies that decide that they're going to dispatch anyway over time are going to say, why are we going? And it's just going to be, you're going to hit alpha, you're going to get the doc, and then, yeah, your alpha calls may go up, but you're not getting dispatched to it.
This really is
and it's still cheaper for the system than going to the ER. So in the end, long term, it's decreasing the dollars spent on Medicaid.
As long as the alpha calls don't go up where you're dispatching the ambulance.
But that's what you decide to do with your system. That's not a regional thing.
So, Mr. Chair, just UCM I happen to be here for the reason that I'd be willing to talk with the Remac, but anytime. But I just want to say that UCM increases quality. We're glad to have the proposal on putting a quality layer that's independent of our organization on top of this. And we're glad to be working with so many agencies in our community on this. And if agencies don't want to work with us, that's okay too. And we would embrace, if the Remac feels there should be standards set, we would work with you on setting those standards.
Which I think we should probably tie into waiting for the ET3 to come out and see, and then finalize the details, which is, actually according to ET3, is between each specific service all the way through. We just kind of got everybody together to have a consistent application for each of their services. So it's approved by the states. We basically said we agree we'd go along with it. Not much else that we
This is the direction things are heading.
can add to it.
And I think we need to give it a shot and see how it goes.
Yeah, it's a lot safer than everything that they've tried before.
It's gonna be a while before we have data, I'm sure,
Yeah.
but.
I just think we need more direction from Remac because EMS does work within protocols, and we would feel more comfortable even through Troy Fire if there was
Technically, you're still working through the protocols because they're all remote docs. So
Well, actually,
technically, it's having a remote doc.
I think the idea of actually having policy here makes some really good sense. And, forgive me as I just sort of try to work through policy in my head right now. But I think policy number 1, all telehealth encounters must be done by a remote physician. All right? I think the next thing would be that we endorse the inclusion and exclusion criteria, which can be done either by dispatch or by the provider in the field if they choose to engage telehealth from the field. Those inclusion criteria, by the way, were something that we spent a lot of time vetting and spent a lot of time on in general with the
And we have
with
the
these things.
inclusion exclusion criteria of what the urgent cares will take from the field.
As well, right. And I think the other is that there must be, for a program like this, there must be an independent, regional quality oversight to it, to make sure that indeed the right stuff is happening for our patients. I think those are the three elements that I would put in a policy.
I wouldn't do any policies right now. Right now, you have some people that have never heard of this, other people that are very involved. I was actually at a meeting about this before this meeting. So before we create any policies, I think Steve needs to give us a nice presentation, come with data. You did a great job for doing this off the cuff, by the way.
Exactly.
Coming up with numbers, just right off the top of your head, very impressive. But before we do anything, I think we need to let them collect the data, make a presentation. It may even be too soon. Maybe we should give you 6 months to get stuff together. I don't know, Steve, that's up to you. I don't know what you've got in your pocket or not.
I mean, I think Dr. Daly raises some good points, like, but we're not doing anything that's not being run through the Remo physicians, like the medical director for dispatch in Rensselaer County, or the medical director for Troy Fire, or the medical director for Mohawk Ambulance, who are all people, credentialed by this body. We've talked with Dr. McHugh about some things in Schenectady. So I don't think we're placing anything at risk here by allowing those Remo physicians to help us guide where we want to go. But we understand that the regional council may wish, the Remac may wish to have some policies. And over time, like you said, as we get more information, we can develop those policies.
So
I mean, there are other treated home initiatives going on, obviously. Those are also well thought out and carefully planned, working with Remo physicians as well.
So I would say probably for April, we'll make this a discussion. We'll hopefully by then know whether ET3 is going forward or is punted until December. By April, and then if we find it before that they punt it, we can delay it. But this way we can have a familiarization for those who aren't involved at April. Have some more discussion on it, hopefully more concrete discussion, because we'll know ET3 is coming or not.
And to be clear, I don't want to stop or decrease anything that is currently ongoing, Steve. I'm just looking for providing education for those that don't have it.
We'd be glad to present. But you know that I'm a little long-winded, so I'll have to practice to get it short.
We'll practice.
So Bruce, are you making a motion now? Because there's actually a motion on the floor already.
I'm not making any motions at all. My recommendation is that we need more information before we do anything. That would be my personal thoughts. Because this is hitting some people from complete left field, other people we know this intimately.
I suggest looking at the minutes for the last 9 months, because it's all tied into the ET3 discussion.
I think it was, but it was never discussed that there was going to be telemedicine that I remember.
Because that was the whole reason why we were accepting of ET3 model, because we were putting telemedicine into that.
We were very specific about telemedicine throughout that entire process. In fact, we talked about the New York City process as not having telemedicine involved, and how that was something that we were unwilling to do here.
So,
that we wanted to make sure that we had that direct physician oversight.
but we talked about having ET3, which has not been approved yet, and we have, when I recall, a number of agencies that were going to.
Don, the only thing that ET3 is different than this is the fact that ET3 is for Medicare patients, and this is for Medicaid patients.
Okay.
Or if this program is successful, all patients.
Well, I think this is a great idea, but as Bruce has pointed out, some of us have heard nothing of this before today. So I think moving on, putting a motion on the floor and voting on it, not to mention I don't think you have a quorum now to vote on it anyway, is not a great idea. I mean, I think it's a good idea for Steve to come in, give a little more information to those of us who don't know that this was occurring or had started as of yet. I mean, I've been very familiar with Landmark, but I've not been familiar with this. That's personally me. And I don't live in Rensselaer County, nor do I have anything to do with Rensselaer County. But I would suggest that we get more information for everyone else, and maybe next time we'll have a quorum, and we can make a reasonable motion. And I'm not sure we need a motion. If the health department says it's good, then so be it.
But we do, at some point, we'll need a motion that if you're gonna do it here, it needs to be a Remo physician giving orders to.
Well, no, actually, I think, no, Don raises a very different question, which I think is a much more dangerous question, okay? Which is, if we're gonna do it here, right, do we have no control over it? Because the Department of Health has said that it's okay. I find that to be extremely dangerous as precedent. And that's something that actually we had long conversations at Med Standards this year, the last month, that Don didn't bring up in our discussions about whether or not regions can maintain and then remove credentials of providers. Right? I think that giving away that home rule for our region is extremely concerning. And I think the idea of at least starting with a reasonable, cogent policy that will apply safety overlying what is already happening out there, and frankly, which the people that are already doing it are compliant with, which makes it much easier. Right? We're not taking any programs that are in existence and pulling them back. Right? What we're doing is taking policies that we've already had conversations about and applying them to things that exist. And I think that is a very reasonable way to move forward with this. You're right, we may have lost a quorum, but I think that at the very least, starting with that policy, if we still have a quorum, would be a reasonable place to start.
So my understanding is the region already has a policy that me as a provider, to get medical control, whether it's telemedicine or any type of, if I call the medical control number or if I talk to a doctor on a screen, it has to be a Remo doctor. That's a Remo, that's...
No, not necessarily.
So if you talk to a physician that is receiving the patient, they do not have to be a Remo physician, but they have to be receiving the patient.
Okay.
In this case, you're talking to somebody on the other end of a telemed connection. The Remo credentialing means that that's a person who's been vetted, has been trained, and knows what to expect from the providers within this region.
So at this point, your criteria is it's either going to be a doctor who's receiving or it's going to be a Remo physician. So either way, you're still covered under the Remo policy.
It's not going to be doctors receiving because none of the ER docs are on the phone.
Right. So you're either talking to a Remo physician or you're talking to no one.
Yeah.
So the region already has a policy in place for now that says this is what you have to do to be able to get medical control orders. So if I call Albany Med, I can call Albany Med and ask if I can bring somebody to an urgent care. They're gonna tell me no, but I mean, in the future, I mean, that could potentially be something that happens as well. You never know. So right now, you still have to talk to a Remo physician though. You have to talk to somebody.
So what we
still
have so
a
far-
policy that says you have to talk to that person that's credentialed.
So right now, in terms of alternative destinations, the only things that we've talked about are doing alternative destinations via telehealth. We've not had any conversations about doing alternative destinations just by calling a doctor. So you're not gonna call St. Peter's or Albany Med and say, hey,
Right.
listen, I've got somebody with the sniffles, can I take them across the street?
But the
Instead.
region also has the policy that says you need to call a Remo physician, or the receiving, which we realize that that's not going to happen. So we already have a policy in place that says you have to talk to a Remo physician. So we don't need to make another policy right now that says anything until we have more information.
I think the clarity on that is, the policy is going to speak with a Remo-approved physician, not necessarily a Remo physician working in the emergency department, a Remo-approved physician, whether it be at this company or in one of the emergency departments. The fact is, it's a Remo-credentialed physician.
Yeah, like we have with Landmark, but you have to now anyway.
Yeah, right. So it's a done, it's kind of a done deal.
Mike, I don't know if you want me to bring that up about the issue that you brought up about discussion at CMAC, so. And that was a public.
You can't bring it up and then not tell us.
Well, since Mike brought it up, there was and this has nothing to do with telemedicine, so we'll just.
So we're tabling telemedicine until
Table.
April.
I got 2 minutes, it's table.
All right, why don't we table it? If Steve could give us a presentation, that would be great. What was brought up at CMAC, and also at Med Standards, there was a Remac that removed a provider from being able to provide care in a region, and it was found that they did not have the ability to do so. According to the state,
There's no statute.
there's no statute that says we as a group can say, I'm not saying we do this, but one of our paramedics is sitting over here, all of a sudden we decide that they're not capable of providing care in our region. The medical director of that agency can do that because they're operating under the medical director. So Bruce could say one of his paramedics can no longer provide care in specifically his agency. But we as a group cannot take that paramedic and say you cannot provide care in the remote region.
Even as a medical director of the region?
Nope.
Really?
There's nothing that supports that in
Why do we have
statute.
to- Why do we have to fill out an application to get online messaging?
Exactly.
Didn't we go through a giant discussion where we decided that if we as a medical director took somebody offline, we would then bring it back here to tell all the other medical directors and then allow them
Watch
to
out
make
for
their
this
decisions?
person.
That was the discussion, as I recall.
Is that allowed?
Well, that becomes a real legal issue that we'd have to discuss with.
So in this
remote
region,
attorney.
the individual who was suspended from practicing in the region turned around and sued the region and all the individual medical directors. And he has basis.
And I think actually the most concerning thing, Beth, that was brought up is that while Article 30 very clearly indemnifies members of this body for things that they do as part of this body, the region had to supply the attorney to defend the members of the Remac, rather than that being supplied through the Department of Health because of the language in Article 30. And that, I think, was one of the things that was also of grave concern to the members of the table. So bottom line is, right now, it doesn't look like there is a way for a region to decredential people. I think it is extremely important that we, if we have somebody that we believe is a potential hazard to personnel, as requested by the director of the Bureau, that person, rather than having any potential for review of their case here, is immediately reported to the state, and the state can do the investigations. Because they have the protection of law, and the people at this table do not.
There is
New
a,
York State will only remove for violations of Article 30.
Or danger to personnel, or danger to patients.
That's a iffy one, because they
That should not
declined,
be
they
iffy.
declined to look at one where it did not overtly violate Article 30. And I think that's the discussion that Dr. Ishkow is referring back to. It's our most recent discussion. And if I recollect that one, there was general agreement that it would go to the state and there would not be discussion amongst the physicians.
I think from now, we just change our practice.
What, and talk to physicians?
No, that these cases, based on what has been delineated to us at the state, if this is something that a medical director believes goes beyond concern for quality at their own agency, that needs to be reported to the state.
Mm-hmm.
And
That
that
was
this
the
body
outcome.
does not, that this body does not bear any responsibility on it.
May I make a
Steve?
suggestion that we have a pathway written out, so should a medical director call, because it happens so rarely, no one can remember this off the top of their head. So somebody's gonna call here and say, so what do I do? And we send them Form 763 that says, call this number, do this.
I believe actually what Ryan Greenberg, was it Ryan or Steve?
It was Steve Zuri.
I think it was Steve Zura said, actually, call Tom Fortune. So we will have a policy that includes Tom Fortune's phone number.
But they have the power to summarily suspend someone's certification pending an investigation. And it all had to do with due process. That a region doing this, they did not give the person due process in suspending their certification, and the state has the ability to suspend pending investigation and due process.
Okay. And I just want to have something for the medical directors to follow a pathway. They're going to know enough to call here and it's going to end.
All right. I think Steve has something.
Not an attorney by any means, but Dr. McHugh will hate me for this, but Dr. Daly might love me as the rest of you. But so if the Remac had a policy that the chair of the Remac had shared medical direction responsibility for all agencies. Yes.
I don't know. You're thinking.
I don't think the agencies would want that.
Yeah, I don't think that's right. Yeah, I think that's a great idea.
It's actually a really interesting idea, though. It is a really interesting idea. That's the equivalent of 249 cc's, I think, though. Sorry, no, that's 49.
You turned the video off, right?
Form 763B.
Can I make a motion to adjourn?
Second.
See you in April.